What's up, Gestalt Education Nation? Today's episode is brought to you by The Payday Practice and our good friends Jeff Langmaid and Jason Deach.
So how would Seth Godin, Gary Vee, and Tim Ferriss create a chiropractic practice? The answer is in this book right here. So our good friends Jeff Langmaid and Jason Deach, they created the Payday Practice to basically show you how you cover your monthly expenses in one day every month. Guaranteed. Generating monthly recurring revenue in your practice can create financial freedom, eliminate chronic financial stress, and turn the first day of each month from damn, it's time to start over to payday.
Get a free copy today at www.thepaydaypractice.com. The Payday Practice will show you the exact step-by-step process that you can use to generate monthly recurring revenue in your practice. Get your free copy today at www.thepaydaypractice.com.
All right, everyone, welcome to another episode of the Gestalt Education Show. Brett, we're back on home turf again. It's good to be back home. Yes. I know, we were kind of on a travel stint there for a while, but this has been a long time coming. So this is actually the first time meeting our next guest for me, even though, I've been lucky enough to share a ton of patients with you. The head orthopedic surgeon for the St. Louis Cardinals, partner at St. Louis Orthopedic Group here in St. Louis, the one, the only Dr. George Paletta. So, Brett, you have a pretty intimate relationship with George with your days at the Cardinals, but then you've also had a little repair done by George, huh?
He's done two repairs for me. He repaired, he did a labral repair on my shoulder, and he did a revision on my patellar tendon. Yeah, so he has been, very near and dear to my heart. And I told the people in the seminar before, which Dr. Paletta just got done helping us out with our DNSC seminar, and the one thing that I learned to really appreciate about Dr. Paletta is his ability as a doctor to be able to use differential diagnosis to really understand what the problem is. And like in the world of professional baseball, you have to understand the stages of tissue healing to know how long somebody's going to be, on the injured list and things like that. And I think he's an absolute savant that way. But the true story where I really was like, okay, this guy is so intuitive and great what he was doing. We had a pitcher, not to name names. He had a real specific pattern of paresthesia, and we were kicking around the idea maybe it was radiculopathy coming from the cervical spine, maybe a TOS variation, and we were basically telling him what it was over the phone, and he over the phone knew that it was a musculocutaneous traction nerve injury. And it was the most wild thing. And even as much respect as I had for Dr. Platt at that point, in the back of my mind, I'm like, I can't imagine that's that. And sure enough, they get the nerve conduction test. Guess what it was? Yeah, that's what it was. So, Dr. Paletta, what are the key attributes to the great physicians in the world that are so good at being able to work through a differential diagnosis? What allows you to be good at that skill?
Well, first of all, thanks for having me. All of those things that you said are all true, and you and I are friends and we're great colleagues, but the main reason I'm here is you serve great wine and we're enjoying some of that right now.
I didn't even introduce it. We have got a crazy bottle of
That's correct.
Beckstoffer B sellers, and so we lured him out with that.
So it makes it a lot easier to talk about all these fun things. I think that I did my medical school training at Johns Hopkins University in Baltimore, and that's one of the great U.S. medical institutions, and one of the premier founders, Sir William Osler, internist there, used to say, listen to the patient will tell you what's wrong. And I think it's really a matter of listening to the patient, really synthesizing and assessing and understanding what the patient's telling you. And most of the time, you'll have a pretty darn good idea of what the diagnosis is before you even lay your hands on the patient, if you really listen to what the patient has to say.
Right. Yeah, that's fascinating.
Well, especially in a world where maybe the people are telling us that we shouldn't be making orthopedic diagnoses off a physical exam and stuff like that. How much pressure do you put in, or how much credence do you put into that first initial encounter talking to the patient, and then also in your hands-on orthopedic exam?
Well, I think that the way I approach it is the workhorse of a diagnosis is the clinical history. You then perform a physical exam with the purpose of trying to confirm what your suspicions are, what your differential diagnosis is. And then imaging studies are really the supportive information to confirm the clinical diagnosis you've already made. We don't operate on MRI scans. We don't operate on x-rays. We operate on patients.
Right.
Which means we operate on the history, the exam, the symptoms that they're experiencing, confirmed by objective studies such as MRIs, x-rays, CAT scans, and the like. So it's really a combination of all of those things. But for me, it starts with the history and the story that Brett told you about the muscocutaneous nerve palsy. I was on the telephone. I didn't have a chance to put my hands on that athlete. I didn't have a chance to examine that athlete. We had no diagnostic studies at that point. But the history, if you listen to it carefully, and if you listen to where the athlete told you their numbness was and what their symptoms were, it, for me, made muscocutaneous nerve number 1 through 9 on the list. And number 10 was going to be something even more unusual than that.
Right. So as time's gone on, like the research on orthopedic testing as far as sensitivity and specificity, it's not great on orthopedic test. So how important are the orthopedic tests that we've all learned in school? Do you still use them? If we're talking about the shoulder, which ones do you like? Today we're talking about a slap lesion. What are the, of course there's the O'Brien, but do you have other ones that you like for slap lesions? And
sure. Well, I think that, your statement is a fairly broad one, and I'll disagree in some respects. So there are some clinical exam tests that are highly sensitive and specific, right? Think about the Lockman test and the pivot shift test for ACL. That's almost diagnostic of some instability of the knee, particularly ACL instability. In the shoulder, it becomes a bit less clear, a bit more muddier. So you mentioned the O'Brien's test, which is a classic slap tear test. It's also known as the dynamic compression test. It was described by Steve O'Brien, who was one of my mentors at Hospital for Special Surgery, where I did my residency training. And in Steve's initial study, he documented sensitivity, specificity, and accuracy of over 90%. Nobody's been able to reduplicate that at all. No other examiners. Right. So that's a test that has to be combined with other tests, and you can't hang your hat on that test alone. So, for example, with slap lesions, there's other tests such as the dynamic label shear test. There are a couple of different KIM tests, KIM tests, described after the surgeon that noted those. So, in my hands, if the clinical history is suggestive of a slap tear, then I look at the totality of the physical exam. Are there more than one of these signs that are suggestive of a slap tear? If the only sign that's positive is an O'Brien sign, the predictability of that is probably relatively low. But if they have a positive O'Brien sign, they have a positive dynamic label shear test, they have a positive KIM test, then you're talking about a patient which is more likely going to ultimately be proven to have a slap tear. So you can't hang your hat on one particular test in any one given situation, unless you have a test like the pivot shift maneuver or the Lockman maneuver for the ACL.
Right. And you've worked on so many big names in professional sports, particularly baseball. How does do you feel different pressures when you're working on like the hometown hero here of the St. Louis Cardinals, whoever it might be? Do you feel the pressure kind of ramp up in that case versus general population, or have you done it so long that, it's just kind of old hat for you?
People generally don't believe this, but let's talk about an elbow, right? Once the arm is prepped and draped and I'm performing my surgery, the ulnar collateral ligament is the ulnar collateral ligament, whether it belongs to Adam Wainwright or it belongs to Adam Wayne, a high school player. It doesn't really matter. If you let that creep into your head, then yes, potentially that could bother somebody. But the fact of the matter is that the way I treat Adam Wainwright is the way I should treat every patient. I should give my patients the best I can give them, no matter what level they play or participate at. Now, is there outside pressures? Yeah, because Adam Wayne, the high school kid from Troy, is not going to likely show up in the newspaper, but Adam Wainwright is. And, those factors come into play in terms of managing the pre-op and the post-operative information. But in terms of the surgery itself, really, ideally, every athlete gets the same approach.
Right. how have you dealt with adversity through your career? I mean, I think we all have stories, like not everything always goes great for us. And you and I have had a lot of conversations where sometimes you're put in a situation where you're basically compromised. Like there's a no-win situation for you in the current situation that you're dealing with. Right. How do you get around that? These inflection points in your career, like how have you grown from those and things like that?
Well, I'll tell you an interesting story. I know you told me before we started this podcast that you had Dr. Andrews here one time. And, fortunately for me, unfortunately for me, I never directly trained with Dr. Andrews, but fortunately he's been one of my biggest advocates. And it goes back to a story very, very early in my career taking care of the Cardinals. I spent my first 3 years in practice as the assistant team physician for the Mets. My mentor, Dr. Alchek, who's still the head team physician for the Mets, was kind enough to invite me on as an assistant team physician when I first started my practice. And that was really the springboard for me getting the Cardinals job here in St. Louis in 1998. In 1998, I was 35 years old, so I was on the very young end of the age spectrum for head team physician. And I went to my first spring training, and this is all public knowledge, so me discussing this player is not a violation of any privacy rules. But Alan Bennis was one of our young stud pitchers at that time. The year before I took over, Dr. Andrews had operated on Alan for a shoulder issue. So I got to spring training and did the preseason pre-participation physicals, and Alan's shoulder, quite honestly, wasn't very good. And I was a 35-year-old first-year team physician, and I failed Alan on his pre-participation physical and wouldn't clear him for spring training. And he looked at me, and the club looked at me like, "Who the hell are you, little snot-nosed kid? You don't know what's going on." And so Alan decided, I'm going to go back and see Dr. Andrews, because I told Alan that, in my opinion, he needed another operation. I said, "You know what, Alan? That's a great idea. Go down and see Dr. Andrews." Because at that point in my career, I figured that if someone like Dr. Andrews advocated for me and agreed with what I was telling players, that was a way for me to build credibility with my new team and with my players and the like. So he goes down to see Dr. Andrews, and Dr. Andrews agreed that his surgery had failed and that Alan needed a second procedure. At that time, we were still doing some open surgery on athletes where we opened up the shoulder as opposed to doing it arthroscopically. And I had recommended a open procedure on Alan. Alan comes back and says, "Hey, Dr. Paletta, Dr. Andrews agreed. He thinks I need another surgery, but he said I shouldn't let anybody do an open procedure. He thinks we ought to do it arthroscopically. And I'm going to go down to see Dr. Andrews." And I said, "You know what, Alan, that's great. I didn't want my first case with the St. Louis Cardinals to be a revision on one of our stud pitchers, right?" So he says, "You know what? I'd love you to come down with me because you're going to be involved in the rehab. And would you mind coming down to Birmingham when I have my surgery?" And I said, "Not a problem, Alan." So we fly down to Birmingham. Dr. Andrews puts him to sleep, gets him on the operating room table, examines his shoulder. His shoulder's unstable, and Dr. Andrews turns around in his southern accent, and he says, "Good God Almighty, son, I think he needs an open procedure." So I looked at him and I said, "Dr. Andrews, that's exactly what I told him, but you told him not to let anybody do an open procedure on him." So Dr. Andrews goes ahead and operates on him, does arthroscopic procedure, everything goes fine. And at that time, Dr. Andrews was partners with a very famous orthopedic surgeon named Bill Clancy. And Dr. Clancy happened to be the president of the AOSSM, our big sports medicine society. This surgery took place in March. Our meeting was in May, and I'm out at dinner with another orthopedist, and Dr. Clancy comes in with his presidential medal on, with his entourage. And he comes by our table, and the other orthopedist says, "Oh, Dr. Clancy, you know Dr. Paletta." And let me go back a second. After Alan had his surgery done, we go out to meet with Alan's family. And Alan's family is interested in, A, what was done, B, why didn't the first surgery work? And the way the conversation went, it somewhat implied that the rehab may have been a factor in the failure of the first surgery. So the family turns to me and says, "Dr. Paletta, I know it's not your fault, but, maybe Alan should do his rehab in Birmingham." And, at the time, Dr. Andrews' sort of standard was the athlete would have their surgery, they'd come back to their hometown, they'd do their therapy in their hometown, come back for occasional checkups. So I said, "You know what?" I said, "You're exactly right." I said, "This is what we're going to do." And I'm a 35-year-old team physician. I've been the head team physician for about 4 months at this point. I said, Alan's going to spend 2 weeks in Birmingham and 1 week in St. Louis, and 2 weeks in Birmingham and 1 week in St. Louis until he's back pitching again, because we can't screw anything up in a week. And I said that right in front of Dr. Andrews. So 3 months pass by. We get to this meeting. I'm at the restaurant. Dr. Clancy comes in. The fellow that I'm meeting with introduces me to Dr. Clancy, and he grabs me by the back of the neck. He says, young Dr. Paletta, you're exactly the man I've been looking for. And he takes me over to the corner of the bar, and for 45 minutes, he just gives me the business. Who did I think I was? Do I have any idea how much Dr. Andrews has done for sports medicine? Who am I to, talk to Dr. Andrews like that? So on and so forth. And I'm thinking, okay, my career is done.
It's over.
Take the shingle down.
I'm done. The president of the AOSSM, Dr. Andrews' partner, has just given me the business. So after 45 minutes, he says, you really need to think about, what you're doing and what you're saying. And I'm like, oh, okay, I'm finished. The very next day, I get a call from Kevin Wilk. Kevin Wilk is Dr. Andrews' very famous physical therapist. He said, George, he said, I heard about what happened with Dr. Clancy. He said, don't listen to anything that guy said. He said, I cannot tell you how much respect Dr. Andrews has for you, because you as a young team physician were willing to stand up for yourself and willing to stand up for your player. Dr. Andrews had nothing but the greatest respect for you, and he will be your advocate for the rest of your career. And that's been the case.
Wow.
So the lesson I took from that is that be an advocate for yourself, be an advocate for your patients, stand by what you believe, and don't let anybody else intimidate you.
Don't get bullied.
Don't get bullied.
Yeah.
And from that point on, Dr. Andrews has been nothing but fantastic supporter of me. Anytime early in my career a player went down to Birmingham, Dr. Andrews would say, let's say it was Albert Pujols. Albert, you got the best guy who could ever be taking care of you in St. Louis. He knows your shoulder best. He knows your elbow best. You need to go back to St. Louis and let George take care of you. And it all stemmed from that episode of not getting intimidated and not being afraid to advocate for myself and stand up for myself and stand up for my player. Basically.
Did you ever patch it up with Clancy, or did it?
Yeah, I patched it up with Clancy. I patched it up with Clancy. Yeah. Took a little help from a couple people, but we got it patched up.
That's a good thing. That's a good thing.
What about, so we'll move on to the medical marvel of the Tommy John surgery. So the Tommy John surgery, the first one was done in 1974 by Job, right?
Correct. 73. Yeah.
Okay. Mm-hmm. On Tommy John. So how much has the surgery changed? What are the differences?
I'm going to ask a little trivia question first for both of you guys.
Let's see if I can get it.
Everybody knows who the first player was.
Okay.
Tommy John, right?
Of course.
Who was the second player?
The second, was it Sandy Koufax?
No. Sandy Koufax never had surgery.
He needed
never had Tommy John. Yes, he did.
I'll know the name.
You will. He was pitching. He was a pitching coach here with the Cardinals for a while, and also with Houston. Brent Strom.
Really?
Yep. He was number 2.
Number 2.
He was number 2, and he never came back. So good thing he picked Tommy John for the first one. Brent Strom was the second.
No.
Okay.
Mm-hmm. And I didn't know that till Brent Strom was here with the Cardinals.
No, I didn't.
We were talking one day. Yeah.
Okay.
Absolutely. Yeah.
So I mean, we're talking. I mean, it's been 50 years. So what have been the changes? What's the future of Tommy John surgery? We always joke that we hate how good Tommy John surgery is because it doesn't make sense to change poor mechanics and stuff like that. They can have the surgery, throw with their shitty biomechanics, and basically get back to where they were, right? So,
well, Tommy John surgery, as you said, was initially described by Dr. Job, and for many years, the Job technique was the only technique out there. In the early, 90s, Dr. Alchek, one of my mentors, described the modification of that docking technique. It was just a change in how the tunnels were handled, but it still used a tendon graft and was pretty much a reconstruction. And those were our two primary options for another 20 years or so. And more recently, we're in another period of evolution. You guys have probably heard of the primary repair, in which the ligament is repaired and reinforced with a thick piece of suture called an internal brace. And there are now hybrid techniques that have been developed that include a tendon graft plus this internal brace. So I think the point we're at now is really trying to fine-tune what operation is best for what player. And there are multiple factors that go into that. What's the pattern of injury of the ligament? Is this a first-time injury? Is it a chronic injury? What's the age of the player? What's the expectations of the player? So I think over the next 3 to 5 years, you're going to see us fine-tune those options and get to a point where we better understand that a primary repair is the best option, for example, for a high school player with an acute first-time injury, and a traditional reconstruction is best for that middle-aged player with both old and new injury to the ligament. And maybe a hybrid is good for that older athlete who doesn't have as long a horizon to come back and pitch on. So I think we're in a real period of evolution in looking at a variety of different options as to how to best treat the ulnar collateral ligament injury.
Right. So why do we have such an epidemic problem?
Well, people have looked for a long time for sort of the magic bullet as to why athletes get ulnar collateral ligament tears. And it's been very difficult to pinpoint any one thing. What we do know, and we know quite well, and you guys have all seen this, is that particularly in the last few years, there's been this incredible emphasis on velocity and on peak fastball velocity. Every kid now wants to throw 95, right? And kids come to my office. I say hello. I introduce myself. What are you here for? Oh, my shoulder's bothering you. What do you do? I'm a baseball player. What position you play? I pitch and I throw 92 to 94. That's the first thing out of their mouth. Because if they're not throwing at that level, it's hard for them to continue to move on, right? But what we know is the one thing in particular that correlates with an increased risk of ulnar collateral ligament injury is peak fastball velocity. Athletes who throw over 95 have a significantly increased risk of ulnar collateral ligament tear. So if the emphasis is on getting these kids to throw faster, and we know that increased pitch velocity correlates with an increased risk of injury, it's not a surprise that we're seeing some increase. Now, that's not the only factor, right? As you guys are well aware, there's much, much, much greater emphasis on year-round baseball play.
Right.
And you got to look at things like workloads, pitching in fatigue states, looking at what deconditioning may occur over the course of a season or over the course of a year. And athletes develop deficiencies that aren't identified in terms of shoulder strength, core strength, lower extremity strength, range of motion. So it's multifactorial, but for me, it comes down to this emphasis on year-round single sport specialization and this emphasis on maximum pitch peak velocity.
Sure.
As two of the main contributing factors.
What do you think about, like, if we look at the ACL tearing, like you see, some of them being, attributed to metabolic changes, hormonal changes. Do you think that is a play for the UCL or not so much? Not so much because, the majority of these injuries, this is almost a baseball specific injury. A male injury. In my career, I've done close to 800 ulnar collateral ligament reconstructions, Tommy John procedures, and over 300 primary repairs, so over 1,000 UCL surgeries. I will tell you that 98% of those are male and 95% of those are baseball players. And of the baseball players, the vast majority of them are pitchers. So in the United States, this is a baseball injury. Sure.
We occasionally see it in wrestlers who get chopped, occasionally see it in gymnasts. We don't have a lot of javelin throwers here in the United States. Right. Although I did do a UCL reconstruction on a javelin thrower who ended up winning the Pan Am Games. So we see those occasionally. But it's a baseball injury. And so, there's not the hormonal variation in males that you see in females with the menstrual cycle and the like. And there doesn't appear to be a clear age delineation. I mean, we see this across the age spectrum from, mid-teenagers up until the more mature pitchers, 30s and 40s even. What normal variants or differences do you see? Like when you're in there, does every UCL ligament look exactly the same? Absolutely. Yeah. Not. Speak on, some of the differences that you see. And it depends on, right? It depends on how many miles are on the tires. Yeah. Right. Typically, if you're operating on a professional who's been doing this for greater than a decade, the ligament is going to be thicker. It's going to be more irregular. It may even have calcifications in it. You're operating on a 15-year-old kid who threw a curveball and popped his ligament. off the attachment to the upper arm bone, that ligament's going to look pretty uniform throughout, except for the site of injury. So there's a high variation in the appearance of the ligament when you get in there.
I remember one time in spring training, we were working with somebody who had a suspected maybe UCL injury, and you were educating all of us that were there in the room that the UCL can act like a lot of different things. Like it can create paresthesia, it can cause pain in different spots. So can you speak of like what that clinical picture looks like? Of course, we have the imaging, but what are some of the things that, the athlete is noticing, feeling that would get you to the right diagnosis?
Right. So that goes back to what we started this discussion off about, which is really the clinical history. So if you look at the athlete who typically presents with medial elbow pain, meaning pain on the inside of the elbow, which is where the UCL is, my mantra is that pain is UCL pain until proven otherwise, okay? But what are the other things that can cause pain? Well, the flexor pronator sits over the UCL. The ulnar nerve sits just behind the UCL. You've got capsule, you've got bone spurs, you've got a lot of other things that can cause pain. So if you really consider the typical presentation of a UCL injured athlete, that's an athlete who's going to complain of pain in the medial aspect of the elbow, particularly during the late cocking and early acceleration phases of throwing. As they start to bring that arm forward with the ball in the hand, they're going to be putting a huge amount of what we call valgus load on the elbow, stressing that UCL and producing pain. So if they say, look, it hurts when I get cocked and I start to come forward, UCL moves much higher up on the list, right? If they say, look, it hurts after ball release and follow through and it hurts more on the back inside of the elbow, you may move something like an olecranon stress fracture higher up on the list. So when and where they hurt are important in trying to stratify what the most likely injury is. Then you look at the physical exam, right? And there are very specific tests to assess for the UCL. We do a stress test where we're trying to reproduce that force that's on the arm with the bone, with the ball in the hand. We do a milking maneuver where we put the arm up in the throwing position and we pull on the thumb to create that same load. And then we do that with a moving position, what's called a moving valgus stress test. Those are 3 tests for the UCL. We have a group of athletes that we've looked at. We're currently in the process of trying to get this study published. But what we did was we looked at athletes who presented with and who had presented with a history that seemed consistent with the UCL tear. And what we wanted to do is say, okay, what's the predictability if one of those tests is positive? What's the likelihood they have a UCL? What's the likelihood of a UCL tear if 2 of those tests are positive and if 3 of those tests are positive? And then we correlated that with MRI findings confirming there was a tear of the ligament. And what we found is that if one of those 3 tests was positive, the predictability was 27%. If 2 of 3 were positive, the predictability was over 70%. And if 3 of 3 were positive, the predictability was over 90%. So going back to our discussion about
orthopedic testing
for slap tears, this is one where if one of those 3 tests is positive, you got about a 1 in 3 chance the athlete's going to have a UCL tear. But if 2 or 3 of them are positive, most likely it is going to be a UCL tear confirmed by it. So the history with the appropriate constellation of exam findings can help you differentiate that.
In our world, we call those the clinical prediction rules. It's like the cluster of orthopedic tests.
Right.
Not one test in isolation, but a combination of the tests can get you more accuracy probably in your pathway anatomical diagnosis.
Go back to the history. If the athlete's complaining of numbness and tingling, particularly in the 4th and 5th fingers, ligaments don't cause numbness and tingling. That's going to be an ulnar nerve issue. Now, they may have some ulnar nerve symptoms because they've got laxity of the ligament and the 2 are linked, but the numbness and tingling clearly increases moves nerve issues higher up on your radar screen. So that's where the history, again, is very important.
And then a tricky thing, I think, with medial elbow pain is sometimes you can have an ulnar nerve neuritis without the paresthesia in the 4th and 5th finger, which make diagnosis a little bit more tricky.
Yeah, they can present sometimes with just pain on the medial side of the elbow or pain in the medial forearm, and it won't extend below the wrist or into the fingers.
Do you feel like, let's just say that we took professional baseball pitchers and we did ultrasounds on them and we subcategorize them. And so we had this group, let's say it's, the general pop, it's 12 to 15% of people have a hypermobile ulnar nerve. Do you think you could make it through a 10-year Major League Baseball career with an ulnar nerve that is perching, subluxing, dislocating, whatever terminology you want to use? Do you feel like it's possible, or do you feel like that will always cause a problem in the Major League Baseball pitcher?
No, it will not absolutely always cause a problem.
Okay.
I mean, we've got guys We've got guys, who I've cared for with the Cardinals for 10, 12 years who have a hypermobile nerve pitch who've never had symptoms.
Right.
So just the presence of a hypermobile nerve doesn't necessarily mean that athlete's going to develop symptoms during the course of their career. My experience has been once they do develop symptoms, the likelihood is high that those symptoms are going to persist. But not every thrower with a hypermobile nerve is necessarily going to develop ulnar nerve symptoms.
And I was glad to hear what you said. I mean, it's been one of the more frustrating things to think, like in the conservative side of care, like once we diagnose them with that being their pain generator, on our end of things, we don't have a tool for that athlete. Like it just, we usually, that's when we send them to you for ulnar nerve transposition.
Right.
So, what is the success rate of ulnar nerve transposition? Is it?
It's greater than 95%.
Exactly.
Yeah. It's an exceedingly high success rate. It's a procedure that when I say love to do, I mean, it's a procedure that I can sit confidently in front of an athlete and say, look, you've got a hypermobile nerve. We do an ulnar nerve transposition. This is a very predictable return. And those are the procedures we love as orthopedic surgeons.
Low hanging fruit, yeah.
It's the predictability is so high.
Right.
We want every athlete to get back to the same level of play before they were ever injured. And when we have an operation that works to that level, it makes it that much more satisfying and easier to deal with.
Right. And it's interesting too, like is a lay person who, let's just say that you're following like the sports tick or whatever, and you see common flexor tendon problems. It's interesting when you follow them. A lot of times those end up being UCL injuries, like eventually. So it's been diagnosed as that, and then you follow that injury out, and it ends up being the thing. So I'm assuming you're going to tell us that there's like a prodromal phase of this. You have your obvious one where they know that they felt the pop and they feel the tear, but then you also have this cascade of effects. It's almost like on a continuum of tearing of the UCL.
So I look at this in three different ways. There's an acute tear, like you just talked about. The high school kid throws a curveball, throws a fastball, his mechanics are a bit off, he feels a pop and pain and he can't continue, and he's got an acute tear where he just overloaded the ligament and the ligament failed. There's no prodromal with that at all.
Right.
It's not dissimilar from a kid planting on the soccer field and tearing his ACL because he did wrong place, wrong time. Then you've got the chronic changes, and these are guys who tend to be a little bit older, college player, professional player, where that ligament, as you talked about, this cascade of events, this repetitive stress on the ligament, it's gradually failing over time. And ultimately they reach the point where either because of reductions in their performance, loss of velocity, or because of increasing pain, they end up presenting with UCL problems. And then you've got the combination where you've got a guy who's had some prodromal, not enough to really impact him, but he won't tell you his elbow was completely normal, and then has an injury on top of that. So I tend to look at these and categorize them as acute, chronic, or acute on chronic, meaning a more recent injury on top of an already failing ligament.
Sure. Glenn Fleissig came out with his seminal paper that basically said that the general public or the layperson, they actually thought 50% of people or something crazy thought that you were actually improving performance by doing the Tommy John surgery. Do you notice that? Like, are parents coming to you thinking that they're going to their little Johnny's going to become a professional pitcher if they have a Tommy John surgery? Is it that crazy?
It is that crazy.
Is it that crazy in the wild?
It is that crazy. And it's unfortunate in that, it's not uncommon still to have players come in, particularly younger players with their parents who are having some elbow issues, may have a low-grade sprain or something else, and the parents are looking and say, well, he's going to need it anyway. You might as well do it now. It'll make him a better pitcher. And I look at them and I said, if I could make your son throw 95 miles an hour,
you wouldn't have been able to get in and see me.
The line would be to the arch, for goodness sakes, from Chesterfield to the arch. That's not how this works. Now, the flip side of that is that if you think about the chronic tear, where that ligament has gradually failed over time, what the player might not even recognize is a slow deterioration in their performance, right? And what I tell players is, look, I can't make you any better than you are. What my goal with surgery is get you back to what you were before you got hurt, and then let your talent take you as far as it can take you. There's nothing I'm doing that's going to give you 4 more miles an hour on your fastball unless you yourself are capable of doing that. But in the chronic tear, you can see this slow deterioration of performance that manifests gradually over time. You fix that ligament, you eliminate their pain, and they get back to their baseline before this degradation, before this deterioration began. I'm not a magician. I'm not a wizard. I'm not doing anything magical except getting their body back to the point where it can perform at its peak level.
I've seen some evidence that the time that you would get after your initial Tommy John surgery, is it 7 years approximately that on average? I know there's outliers.
That's a fair estimate. Some recent papers suggest that. Correct.
Right. And then when you have to do a revision, how does the trajectory of that case look like if they've had 2 Tommy John surgeries?
So revision surgery is a place where we as orthopedic surgeons still struggle with regard to outcomes. The outcomes with revision surgery are not nearly as good as they are with primary first-time ulnar collateral ligament surgery. Most studies, most papers reliably indicate that the success with a first-time Tommy John is between 80 and 90%. Whereas with revision surgery, several papers suggest it's as low as 40%. It's a more prolonged recovery, and studies also suggest that there's some increased degradation of performance metrics once they come back after revision. So revision is a place where we haven't achieved to the same level. So those are places where we still hope to avoid ever having to be.
Yeah.
Got another trivia question for you.
Okay.
There's only about 3 guys in Major League Baseball history who have come back from 3 Tommy John surgeries. Can you name one?
Deanne Winkler.
I don't know about that one. That's not the one I was looking for.
He's a trivia guy.
Jason Isringhausen.
No way.
Yeah. And on top of that trivia,
hip surgery too.
I was involved in all 3 of his Tommy John reconstructions.
Yeah.
If you remember when Izzy first came up, he was part of the 3 amigos or the young guns with the Mets.
Yeah, that's right.
It was him, Paul Wilson, and I'm blanking on the other guy's name. And so Izzy tore his ulnar collateral ligament when he was with the Mets. I was working with Dr. Alchek at that point, and I scrubbed in with Dr. Alchek and participated in Izzy's first Tommy John surgery.
Wow.
Izzy then had a very successful career, retore, and I did his second Tommy John surgery. Came back and then had a 3rd injury, and I did his 3rd Tommy John surgery, and he came back from that. So he's one of just a couple of guys that have ever come back from 3 Tommy John surgeries, and I'm fairly certain he's the only one that had the same surgeon involved in all 3. So I don't know if that's a positive or a negative, quite honestly.
You talk about good rapport with the patient.
Yeah, exactly. So.
What about, it's interesting. I think like all the orthopedists, like they get on the same page about what protocols are for like Tommy John surgery and even things in the shoulder. But the one thing I've noticed a huge discrepancy in is the advice given to people with little leaguer's elbow or growth plate injuries. What is your recommendation? I mean, if we're seeing a 12-year-old kid who's got, correctly diagnosed with little leaguer's elbow, what's your recommendation on throwing? How much do we rest them? What's your ideas on that?
It's a very interesting problem because with that problem, there's often a degree of denial that's remarkable, quite honestly. And I'll give you a perfect example. So most of that is an overuse injury, right? Mm-hmm. And we typically see that in kids 11 to 13. They're starting to make the move up to a slightly longer mound. They're starting to focus on things like velocity. And oftentimes their body's not ready for that, right? Mm-hmm. They're skeletally mature. Their medial epicondylar growth plate is the weak link. And if you throw those increased demands on top of, or those increased expectations on top of an increased workload, that's the point that's going to fail. So I had a kid, I think he was 12, maybe he was 13, came in, classic medial epicondylar apophysitis, little leaguer's elbow. I said, tell me how much you're throwing. This is usually related to overuse. And right away, Dad jumped up and he's not overthrowing. He's not,
Which means he is. Automatically.
We're careful with pitch counts. Okay, that's great, Dad. Do me a favor. Kid plays on 2 teams. So that right there tells you there's an issue. said, do me a favor, Dad. For the next 2 weeks, I want you to log every pitch that your son throws. Not just game pitches, warm-up pitches, batting practice pitches, pitches with his pitching coach. And I'll see you in 2 weeks, and then we'll talk about the volume of throwing. What do you think? How many pitches do you think that kid threw in 2 weeks?
I have no.
400.
526 pitches in 2 weeks.
Yeah.
So then with the information in front of me, I said, Dad, you think we have a problem? Because I think we have a problem.
We're finding a different doctor.
So, to go back to your original question, I think we work hard not to take those kids fully out of participation, because oftentimes it's part of their identity.
Sure.
It's part of their peer group. It's part of, there's important psychosocial aspects of that. So if they're really symptomatic and they can't throw at all, you got to take them out of all throwing until they're asymptomatic, until they have their full motion back, until they have good forearm strength. But that doesn't mean they can't hit. Doesn't mean they can't DH or pinch hit. Or if the kid's symptomatic only with pitching, then maybe you move them to first base and say, look, we're just going to minimize your throwing. Do ground balls in practice, but don't do any throwing in practice. Minimize it. So it's really titrating their level of throwing with their symptoms, and also making sure that there's no underlying deficits like range of motion loss, weakness that you can address to help minimize those symptoms. But my number one focus when I see those kids is, let's talk about how much you're throwing.
Right.
Because that's usually the problem.
Do you have a recommendation on, let's say we rested them for 6 weeks or whatever we rest them for, and then we're obviously rehabbing them. Coming back from that, what would be a reasonable pitch count for them, do you think? Or like, what are you shooting for?
So, Jimmy Andrews Group and U.S. Baseball have put out guidelines that are somewhat age dependent. What I typically recommend is I take their age, multiply it by 10. So let's say we've got a 10-year-old, multiply it, that's 100. And 100 pitches is the max over any 2-week period, including all pitches.
Right.
And then you just...
Including warm-up pitches.
pitches. Anything that involves the pitching...
Motion. Yeah.
Correct. Yep.
Okay.
And then you work back over the course of, what would be a typical 4 to 6 to 8 week progression, depending on if they've been shut down completely or whether they've still been doing some throwing.
Is there any long-term consequences to the kids that have had Little Leaguer's elbow, or does it heal up and, the trajectory is fine in that case? Or,
well, in the vast majority of cases, it will heal up. Occasionally kids will avulse the medial epicondyle, actually fracture through the growth plate, and that typically requires some surgical intervention. Sometimes you'll see kids who are skeletally mature, now high school or college players or even pros, where you can see some old evidence of fragmentation where it healed in completely, but it's been asymptomatic. So there's a spectrum of how this heals. Handled right, in the majority of patients, it will heal fully and shouldn't have any long-term sequelae for them.
So kind of the hot button subject right now, and the baseball pitchers at least, is thoracic outlet syndrome. So obviously one of the experts here in St. Louis is Dr. Thompson, but what do you think? Do you think we're operating too much on this problem right now? Do you think there's going to be like a return to the mean, or do you feel like we're not? What's your opinion on all the surgeries now that are happening as far as thoracic outlet syndrome?
So I'm going to give you a mixed opinion on it. I think thoracic outlet syndrome in the elite thrower is more common than we think it is. It is a difficult diagnosis to make because there's no specific confirmatory
It's not
test.
like a traditional TOS case, yeah.
Correct. It's not, but I think at the same time, when I say we, I don't do this surgery, but we as sports medicine physicians think we have a good solution to this, which is why you're seeing so much surgery. But my sense is the pendulum's swung a little too far in favor of surgery. And as we continue to sort of fine tune our diagnostic skills with this and our rehab skills, it'll swing back a little bit more towards conservative treatment. But I think particularly in elite thrower, it's more common than we probably think it is.
Right. Sure. George, you kind of have a legendary reputation for kind of understanding soft tissue injuries, what the healing time is going to be. How did you acquire that skill? Is that just, you've just seen it so much and paid attention to it? how are you able to know? Because obviously with like a professional baseball team, this is a critical thing to know because you're obviously moving people down to different levels and things like this. And how do you get good at that skill to kind of if we're dealing with a difficult oblique injury or hamstring injury, what is your go-tos as far as like knowing how long they're going to be out and things like that?
Well, I think that the way I got particularly good at it is soft tissue injuries, more so than other orthopedic injuries, are injuries that really require a team approach. Okay. So that's a place where the athletic trainer, the physical therapist, the soft tissue specialist, the chiropractic specialist, everybody has an experience there. And I've worked hard to try and aggregate all of that experience with my own observations to really understand soft tissue healing.
Right.
Whereas, if a kid avulses his medial epicondyle and I have to put a screw in it to fix it, I got a pretty clear understanding of what the bone healing is with that fracture and so on and so forth. And then it's just, quite honestly, the advantage of being a team physician for a professional ball club. Okay. I get to see those guys with soft tissue injuries every day or every other day. And I get to follow them much more closely than I do my high school player who I might not see for 3 or 4 weeks. Sure. And I get to control, along with the other, medical care team, the activities of that player. So carefully monitoring that, observing that, and balancing off what really happens with what in my mind I predicted was going to happen has really helped me be able to fine tune that, because I have such an ability to closely follow those patients and observe their recovery.
And they're imaged all the time. And
they're imaged all the time. They're examined all the time. There's input from, again, from your experience with the Cardinals, right? Everybody's got their hands on those players, right? Not just the orthopedic surgeon, the chiropractic specialist, the massage therapist, the soft tissue specialist, the athletic trainer, the rehab specialist, and you're synthesizing all that information and then just, again, carefully monitoring it and balancing it off in my head with what my initial prediction might have been. And I think I've become much better at that over the course of my career than I was early on.
Right. Do we have to be careful in the orthopedic setting of over-educating our patients off their image findings? Like, are you kind of careful the way that you kind of craft your words to them to where you don't create like chronic pain behavior? Meaning, as we talked about with James Andrews' research and others and some of your friends that have done the research on this, we do an imaging on a shoulder, even on people who have no complaint. They have they have fraying of the rotator cuff. We have all kinds of MRI findings. How do you kind of like negotiate that? Like what you're going to educate them on for, you know what I'm saying?
So a lot of it depends on the patient, right? And professional athletes are very informed. Okay. And
that was a political way of saying it.
I take as much time as possible and I run through all the imaging findings and I do my best to identify to them, look, these are typical changes we see in a 35-year-old pitcher. These are generally not sources of pain. This is something you don't need to be worried about. This is not a typical change. This may be your source of pain. And here's what we're going to do to figure it out, right? Take your 55-year-old accountant who's a tennis player, who comes in and has an MRI and it shows a partial thickness rotator cuff tear. I take time to educate that patient and say, look, if we took 100 guys off the street that are in their 50s with no shoulder pain and we put them in an MRI scanner, depending on which study you believe, between 15 and 20% of them are walking around with a rotator cuff tear that looks just like yours. Mm-hmm. So just because it's there doesn't mean it's the source of your pain. Let's try and really identify what the source of pain is. So imaging is a double-edged sword. It will sometimes show you things that are abnormal compared to a completely normal scan, but are not contributing in any way to the patient's pain, weakness, symptoms at all. And it can sometimes be very challenging to get them to get their focus off that MRI abnormality, particularly if they get the MRI report and the radiologist report says partial thickness tear of the rotator cuff. Well, there it is. That's what's causing my pain. And sometimes it's really not. So that's a great challenge. And it takes time. It also takes an ability to communicate with the patient on their level.
Mm-hmm. Right.
Communicating with an 18-year-old high school kid and communicating with a orthopedic resident and communicating with a 53-year-old, laborer, who all have different levels of education and different levels of experience. It takes a real effort to communicate with them on a level where they can understand it.
Right. It feels like now with like the professional baseball player, a lot of times the gatekeeper is the sports agent. So what do you think about like that trend that's kind of occurred over the last 5 to 10 years where it's almost like the agent is the one who's kind of determining where that athlete's, I'm sure you've been on both sides of that.
Yeah. Early in my career, I used to give some lectures about being a team physician, and I had a slide that sort of illustrated the world from my perspective. So it was a picture of Jupiter, and you all know Jupiter has multiple moons, right? Mm-hmm. And in my world, I'm Jupiter, and all of these other moons surround me. And the moons include the player, the agent, the organization, the family, so on and so forth. In the player's world, obviously the player is Jupiter, and in the agent's world, the agent is Jupiter. Sure. But the fact of the matter is, when it comes to the professional athlete, there are a multitude of outside influences that have to be taken into consideration. With the high school player, it's typically the player and his mom and dad. Mm-hmm. With the professional athlete, you're talking about the organization. You're talking about the agent. Oftentimes, there's an individual personal care team that the player has a relationship with. They might have their relationship with their own outside therapist, their own outside physician. And all of those things need to be taken into consideration. And yes, I agree with you. In the last decade or so, agents have taken a more forward role in trying to help guide the care and the assessment of their players. The way I approach that is to engage the agents. If you look at them as an adversary, they're going to look at you as an adversary. Sure. And then that creates a barrier to really providing the appropriate care for the player. And my philosophy has always been, if I'm not the one taking care of the player, let's make sure the person that is taking care of the player is appropriately credentialed, experienced, suited to do so we can be sure that player is going to get an outcome similar to if we were taking care of him ourselves. Mm-hmm. And I found the only way to do that is to engage the agents as partners in the care of the athlete as opposed to adversaries in the care of the athlete.
Right. I want to ask you about some of the intangibles of healing that no one talks about. And what I want you to address is the importance of certainty or confidence, not cockiness, but those two attributes when you're working with an athlete. I bring this up because I talked to one of our professional baseball player who you worked on, who everybody would know the name. And this person said, in the process, the agent was kind of talking about, entertain some other options. But then he talked about, specifically asking, why should I use you as my surgeon? And you basically looked him in the eye and you said, because I'm going to do the best job of, being able to do this. And that's what sold the deal for him. How important do you think certainty and confidence is for a physician to be able to get desired results?
Well, if you think about what's weighing on the injured professional athlete's mind, right? It's not just this season. It's his career. It's his livelihood. Yeah. It's income. It's his self-image, income, everything. Early on in my career, for the first probably 10 years, whenever I had a conversation with a Cardinals player about potential surgery, I insisted that they go out and get a second opinion. Insisted. And I did that for two reasons. One, I did it for my own selfish reasons. I wanted to be sure that I was continuing to get better. And if they went out and saw Dr. Jobe or Dr. Andrews or Dr. Alchek, and those, superstar orthopedic surgeons confirmed what I was saying and what I was thinking, it kept reinforcing for me that I'm on the right track. Okay. And I did it for the player because that player needs to have 100% confidence in what I'm going to do for him and what I'm going to tell him he needs to do for himself post-operatively in order to get the best results. If there's doubt and they're not full in on the rehab protocol, or if there's doubt as to whether I was the best person to do the surgery and they're having postoperative pain or they're having some postoperative limitations and things aren't going exactly as we expect, that doubt then creeps into all aspects of their recovery. So confidence is critical. Now, the flip side of that is one of the things that I take great pride in when I take care of athletes is, I'll say to them, look, you've got a grade 2 hamstring strain. I think that this is likely going to be 6 to 8 weeks, but here's what we're going to do for the next 2 weeks. And then in 2 weeks from now, we're going to reevaluate you and we're going to modify those timetables and modify the treatment if needed. So I try and give the athlete, particularly the professional athlete, a smaller window in which to meet expectations and then adjust those expectations accordingly as we go forward.
Right.
And that is designed to improve their confidence, because if they've met those expectations that I've laid out for those first 2 weeks, they're like, man, he's on it. We're on it. We're going in the right direction. And if they haven't, then I look at them and say, remember, I told you we'd reevaluate it 2 weeks. And if we need to change things, we'll change things. That tells them, hey, I'm not exactly where I'm supposed to be, but we're still on top of this. And he told me this was going to be a possibility. Let's move to the next step. So that's the way I approach it. But instilling confidence in any of your patients is critical, and no more so than in the professional athlete, where all of these outside influences may be whispering in their ear that you need to go in another direction, or you need to think about or try something else. So,
it's brilliant. I think that at the end of the day, it doesn't matter if you're a physician of any point, people want a plan. It's no different if your contractor comes to your house. You don't want to just say, yeah, I'll get it done. You want to know that what you're paying for.
Let's just kind of see how it, you don't want to hear that.
No.
You want to hear
they need a plan.
They need a plan.
Even if it differs, like you said, then at least they knew that, you brought confidence to the situation. And that my patients too that I've sent to you have said the same thing. If there's a specific plan and there's specifics going forward, and there's reevaluation.
And that's important, right? Because I don't have a crystal ball. I can't predict everything with 100% certainty, but I know that with a grade 2 hamstring strain, in my experience, 90% of the time, in 2 weeks, I expect you to be at this point. So this is where I expect you to be, Brett, in 2 weeks. Right. And if you are, then we'll move forward and keep going. And if you're not, we'll reevaluate. And it to me, my experience has been that creates a sense of confidence and a sense of certainty in the athlete that, hey, we've got a plan in place. And that's what they want. They don't want the uncertainty of, let's just see how it is. It's been my approach.
Yeah.
And my approach has always been, I say this to young orthopedists who come spend time with me, whatever, on a Monday, I might do 12 surgeries. A couple of Mondays ago, I did 7 Tommy John surgeries. And I still go home every night and I think about each one of those surgeries and what could I have done different or better. So this sense of self-examination is critically important.
So yeah.
And it's the same with laying out a plan, right?
James Andrews said the same he's quite a bit older than you, but at 80 or whatever, however old he is, same exact thing. He said that.
Right. And the way you learn is, right, if I lay out that plan for you and in 2 weeks you're not where you're supposed to be, I say to myself, well, did I miss something here?
Sure.
How can I be more certain next time? And I think that the really great physicians, I think the really great people in any profession do that. They're always looking for an opportunity to continue to get better. Oh, yeah. And in my world, the best way to do that is by self-inspection. I mean, introspective assessment of what you've done.
Yeah.
So.
Oh my gosh, that is profound. Yeah.
I think it's a great way to stop. We kind of hit our hour. George, I thank you so much, not only for educating the people on DNSC this weekend, but then also for sitting down with us. And me personally, thank you for taking care of my patients and the people we send to you. It's I can always tell a George Paletta knee or a George Paletta elbow because they're very clean and it's crisp and everything like that. So I really, really appreciate your magic there. But then I appreciate too how much you've rubbed off on Brett, and Brett's been able to rub off on me as far as sports injuries and stuff like that. And you're a true gentleman, and we really appreciate you being here.
Well, my pleasure. As I talked about, it's a team effort. So I learned as much from Brett as I hope he learned from me. But
Yeah.
That's how it goes. That's how we make our athletes better.
Yeah. That's right.
No one person has all the answers.
Yeah. Well, I really appreciate it.
Yeah,
my pleasure.
Brother. I appreciate it, brother.
Pleasure.
All right, guys.
Thanks,
Well, I hope you guys
having me.
enjoyed this conversation with Dr. Paletta. And as always, continue to get better. Some self-introspection and some creativity go a long way. So good luck with patients, and we'll see you next time. I hope you enjoyed this episode of the Gestalt Education Show. If you liked it, share it, subscribe to it, send it to your friends, send it to someone that needs to hear this message. We really want everyone to be able to tune in and get the best clinical advice that they can, which we're hoping that we're giving to you with these special guests. So if you have any questions, please feel free to reach out to us, or if you have any suggestions on upcoming conversations, let us know. For a list of our upcoming courses, we're adding them all the dang time. So go to gestaltedu.com, click on courses, and they'll all be right there for you. All right, have a good day.